Um, the next item is the first of these external speaker slots that we're going to try and produce each quarter. And I'm delighted that Miles Sibley's agreed to come along and be our speaker. I first saw the document that the patient experience library produced called the Toolkit Mountain a couple of months ago, and got astonished by some of the numbers in it. And I've done some digging into the patient experience library since, but finding out more about where they came from, why they're doing it, and what their intentions are, is what I'm hoping Miles is going to take us through now, with hopefully time for some questions when he's finished talking. So Miles, welcome to the Shared Commitment, and over to you.
Okay, thanks, Roger, and thank you, Jeremy, and thank you all of you for inviting me to join you in thinking about patient and public involvement in healthcare research. What I'm going to be talking about is some work we've been doing on mapping the patient experience evidence base. And I'm going to try and show how that might help to reduce duplication and waste, and also tackle health inequalities. First of all, and very briefly, just to introduce myself, I run the Patient Experience Library. So that's an online research database for people's experiences in healthcare. And we set that up after realizing that an NHS, which says that it wants to be both patient-centered and evidence-based, didn't actually have a coherent evidence base for patient experience. There's plenty of research being done through national patient surveys, the Health Watch Network, health charities, academic studies, policy think tanks, but nobody was pulling it all together and putting it in one place and making it searchable. So we built the library to plug that gap. The library now holds tens of thousands of reports on patient experience and engagement. And we recently started to wonder, what is all this stuff? Who's publishing it? What topics are being covered? And who is it among patients and public that we're hearing from? And who are we not hearing from? And part of the reason we started to ask that was because we could see, as we were collecting all of this literature, that there was a lot of duplication. If you want to know about people's experiences of trying to get a GP appointment, there are hundreds of reports, and they all say pretty much the same thing. At the same time, we had a sense that there were big gaps. So if you want to know about people's understanding of advanced care planning or experiences of pelvic mesh, or if you want to know about the intersection between religious faith and people's experiences in healthcare, you're probably not going to find very much. Now, you will all know that this matters because in healthcare research and policy work, there's a kind of endless debate about how we hear from the so-called hard to reach or seldom heard or underserved. And part of the debate is about which of those terms we should use. But as I see it, none of them really work because they're all so vague. If we're talking about people who are seldom heard, I want to know, who actually are we talking about? And what does seldom even mean? Does it mean we hear from people occasionally, or just once in a blue moon, or never? And as we were thinking about these things, what we realized is that nobody has ever mapped the patient experience evidence base to try to answer those kinds of questions, partly because they can't, because nobody has ever kind of collected and preserved patient experience evidence in a coherent way. The NHS is awash with medical research databases, as you all know, PubMed, Embase, CINAHL, all the rest. But it never had a research database for patient experience. And again, that's why we set up the Patient Experience Library. And the thing is that if you don't have a comprehensive research database, you don't know what you know. And therefore, you also don't know what you don't know. In medical research, there are clear prioritization processes. The bodies that fund research also, to some extent at least, steer the research. They know what they know, and they steer researchers away from duplication and waste. And they also know what they don't know. so they can point researchers towards filling the gaps. In patient experience research, there is no prioritization at the national or strategic level. It's a complete free-for-all. And this is why we have extensive duplication and waste alongside big gaps in our understanding of people's experiences in healthcare. And this is also why year after year, we have these debates about the seldom heard without ever really knowing who they are or where they are or what, if anything, anybody's asked them about. So this time last year, we were very fortunate in getting a £29,000 grant from the Health Foundation's Q community. Thank you, Health Foundation. Thank you, Q community. Q community, you're probably all aware, is all about quality improvement. So that funding was to make a start on mapping the patient experience evidence base. And to do that, we sampled 5 different parts of the evidence base: patient experience in digital healthcare, people's experiences of the COVID pandemic, experiences in urgent and emergency care, the healthcare experiences of homeless people, and experiences of people with rare disease. And then just as a kind of a bonus extra, we also took a look at guidance and frameworks and toolkits for patient and public involvement. And that's the Toolkits Mountain report that Roger just referred to. So that's 6 samples in all. And for each one, we carried out a thematic analysis, and then we produced 6 individual reports accompanied by 6 online open access interactive data visualizations. And when I finish talking, I'll put a link to those in the chat. Now, this was all on the basis of a 29k grant, so we made a little money go a very long way. And I need to emphasize that we weren't, with any of this, trying to extract learning from the evidence. What we were trying to do was show the overall shape of the evidence base. To answer those questions, who's collecting the evidence, how many studies and reports are being published year on year, what topics are being covered in those reports? So, for example, with COVID, was it experiences of lockdown or attitudes towards vaccines or experiences of visiting bans in care homes? And then that question of who's being spoken to and who aren't we hearing from? Now, with 6 separate mapping exercises, I can't go into the detail of all of them. But what I can tell you is that for every single sample of the evidence base, we found areas not just of duplication, but of saturation. In experiences of digital healthcare, 38% of the evidence base, over a third, is about access to digital services. In experiences of COVID, the same, 38% again, well over a third, about access to healthcare during the pandemic. In urgent and emergency care, same again, 35% of the reports we found were looking at access issues. And in homeless people's experiences, half of the reports, 50%, were about access to services. Now, there's nothing wrong with asking patients and public about access to health services. But there is something wrong with asking them over and over again, year after year, and then publishing studies that simply add to the pile of reports without adding to the sum of knowledge. It's a waste of time, it's a waste of money, and it tells us nothing new. With every single sample of the evidence base, we also found gaps. In digital healthcare, very little on people's experiences with the NHS app, very little on experience with electronic health records, very little on public attitudes to artificial intelligence in healthcare. With experiences of COVID, only 6% of the reports we found had a specific focus on health inequalities, when we know that the poorest communities were hit hardest by the pandemic. 5% on attitudes to vaccines, and just 2% on the pandemic experiences of people who are clinically vulnerable. 2%. Healthcare experiences of homeless people, where 50% of the evidence base is about access, we found just 2 reports on food insecurity. Not 2%, just 2 reports. And just 1 single report on experiences of hygiene poverty. And these are fundamental determinants of health in the homeless population. So we have a lot of talk in healthcare about health inequalities. If we want to understand health inequalities, we have to hear from the people who experience them. But our evidence indicates that health inequalities are perpetuated, at least in part, because those same inequalities are built into the way patient experience evidence gathering is being done. People involved in health inequalities often say that underserved communities are not actually that hard to reach. It's just that researchers aren't trying hard enough. I disagree. I think that plenty of researchers are willing to make the effort. And I think your shared commitment group is itself evidence of that. But the huge difficulty faced by researchers is they can't easily see who's already been spoken to and who hasn't. They can't see what topics have already been covered and where the gaps are. And they can't easily get the kind of help that medical researchers get in terms of getting a steer on where to go next. So the evidence mapping work that we've carried out, and as I say, I'll put a link to in the chat to it, it can put an end to the free-for-all in patient experience research. We've created the foundations for prioritization processes of the kind that are routinely used in medical research, and we've created a foundation for tackling inequalities in health by tackling the inequalities in the research. But we can't do all of this on our own. The 29K that we got from the Q community was fantastically helpful in giving us a leg up to get started on this work. But we went way over budget. We spent between 2 and 3 times the value of the funding. We did that because we knew that we could do something extraordinary, something that's never been done before. But we can't go any further with this on our own. We don't have the capacity. We don't have the influence. And as an organization that gets no core funding, we certainly don't have the money. So my plea to yourselves in the shared commitment group would be twofold. First, please have a look at the mapping work that we've done. Looks like Barbara's just put the link in there. Thanks, Barbara, for that. Have a look at the mapping work we've done. Read the 6 reports, read just 1 or 2 of them if you haven't got much time, and go and look at the data visualizations and have a rummage and have a play. The reports themselves are easy to read. We deliberately made them very concise, and the data visualizations likewise easy to use. There's no training required. You don't have to download an app before you start. You don't have to create an account and log in. We made the access wide open, partly because we want to democratize the knowledge. All of the data that's there comes from patients and public, and it needs to go back to them very easily. But also because we want people to dig in and learn. And what I hope you'll see when you look at all that stuff is that funding we got from the Q community has unlocked a huge potential for researchers to stop wasting time, for research funders to stop wasting money, and for the so-called seldom heard to come out of the shadows, and for their presence or absence in the patient experience evidence base to become fully visible. So we really want to build on this, but we can't do it on our own. We've shown that it can be done, and we're willing to share our knowledge about how it can be done. But we need partners, we need collaborators, we need people who can pick this up and run with it. What we've achieved is just a start. In 6 months' time, all of the evidence maps we've created will already be starting to go out of date. And I think it would be a real shame if the whole thing turns out to be just a flash in the pan. I think we've opened up a world of opportunity here for real engagement, real learning, and real progress towards health equity and equality. We can't really lead on all of that, but maybe one of you or some of you or all of you could. So over to you. Thank you very much for listening, and happy to take questions if there are any.